All right, another talk about local anesthesia, injections, something that we do every day in our clinics, minimizing injection pain. I will go over a couple of products, and I have no disclosures to make on those. When I first started looking into this topic, I started by looking at the history, and it's pretty astonishing thinking back to focal anesthetics with folk medicine. These physicians at the time literally would give the patient lettuce to chew on or mulberries to chew on in an attempt to calm them down and give them some form of anesthesia. It doesn't sound too effective, right? So we got more sophisticated in time, and we'd render the patient unconscious by knocking them on the head. And if you were really nice, maybe you'd strangle them to give them some to make them rendered unconscious so you could perform a procedure. In time, we have used alcohol and opium, and then in those days, the surgeons would actually have cotton balls in with their medical supplies, not for treatment of the patient, but they'd use those cotton balls to stuff their own ears to dampen the screams of agony from these patients. You just think about that and kind of where we are, and thank goodness for local anesthetics and IV sedation and stuff, allowing us to do what we do every day. In the 1830s, gases were utilized, ether, chloroform, nitrous oxide, and obviously we've come a long way. Now, I live in Kentucky, and I'm not surprised anymore when a patient asks me, though, if I have a stick that they can chew on. I imagine somebody's asked you if you have a stick that they can bite right before their injection, and no, I don't carry a basket of sticks that are available for patients, right? They ask you if you have a leather strap to bite on or chew. It's not uncommon if they say, hey, can I hold somebody's hand? There is some validity to these things because as the brain is receiving input from various sources, it has to process all that together. And if you can be focused on chewing on something or holding something or listening to something else, for example, the brain is less focused on the pain. So this is a picture from a publication in 1984 where they described verbal relaxation tapes used before an injection to calm that patient down so they can almost form a meditation and focus on something else. Again, this has come a long way, and we don't need these headphones from, prehistoric times. A lot of people have ear pods already in, and we might be able to do some of these things a lot easier. So there are a lot of options these days, mind and body options, like meditation and melatonin and things to prepare a patient theoretically, but it might not be practical in your busy clinic. Looking at some of the literature, and there wasn't a ton, but hypnosis was found to be really good before injections. Well, I don't know hypnosis, and probably most of us don't, right? So we might not be able to do that. More relevant and practical would be giving patients bubble gum right before the injection. It's pretty cheap, doesn't take very long, and after reading the study in pediatrics specifically, I keep some bubble gum around the office, and if the parents are okay with that, I'll offer that to the children. And it seems to be effective, or take their mind off of it a little bit. But it's not just children, right? You all have the patients that have tattoos, sometimes their whole leg or sometimes their whole body, and you would think that they're used to receiving a needle stick, but typically they're not. And if you see somebody with a lot of tattoos, I almost think at this point they're not going to do as well with the injection. I have a location outside Fort Knox, and we have a lot of active military guys, and these guys are big and strong. You'd think they're tough, but I'm telling you, a lot of these guys are the most fearful of receiving an injection. But really, it can be anybody. And these folks might not come see you for months, for years, because they're going to be afraid that you're going to tell them that they need an injection. And if you can make this experience a little easier for them, that might go a long way for your practice. But there really is a true phobia surrounding injections and receiving an injection. It's a mental suffering, a mental anguish that they go through. And this is called trypanophobia. It affects 10 to 20% of the U.S. population. And it's probably why a lot of people don't like going to the dentist, right? This was interesting to me. This is a list of list of results of people surveyed in the U.S. of what they're most afraid of. Number one is public speaking, which I'm still working on. Heights, which you might be afraid of after you see our calcaneal fracture lecture tomorrow. Snakes, drowning. Right, number 5 is blood or needles. Claustrophobia, flying. Then we have strangers, zombies, and clowns. Ghosts and darkness. So it's a real thing and probably affects more of our patients than we might realize. Again, in a busy practice, we're not thinking about this maybe as much as we should, but to recognize that in the right patient's important so they don't have an experience that looks like this. We want them leaving the office, high fives, saying, you know, that really wasn't quite as bad as I expected, and that's how you want to build your brand. And we might not be able to completely erase their fear, but we can try. And I think in what I've researched and kind of my personal experience, I would recommend no surprises. That will take away the anxiety of the process. So I literally tell them the first thing you're going to feel is something that's a little cold and wet, and that's going to be an alcohol swab. We're going to clean your skin off, and then you'll feel this ethyl chloride spray. You'll feel a stick of the needle, and then this will last a couple seconds, and you'll get a Band-Aid and be done. But I don't surprise them suddenly with a needle stick, okay? I never leave the needle in sight either. That's usually tucked away in my pocket, or it's sitting in the tray under the chair where they can't see that. But there's no reason they need to see that needle. If they ask you how long it is, they don't need to see that either. For children, I've even spun the needle off and just showed them the end of the syringe, and it looks like nothing. But if you show them that there's a needle on there, they can't believe how long it is, right? So there's no reason they need to see that needle, and don't show it to them. Set the stage as far as the mood of the room and make this a more comfortable process. And they have music on their phone they might want to listen to. You can let them do that if it's not too loud. If there's ambient light coming in, sometimes I'll even dim or turn off the light. And again, that can just set the stage, set the mood for the procedure. And sometimes it's just a matter of how you talk to somebody or the tone of your voice, the pace at which you're talking, so they know that they're comforted and this is going to go well. They'll feel better. I've also gotten to the point I lay them back. Everybody, I don't ask them anymore. I used to ask, what's your preference? But I just say, all right, at this point, I'm going to lay you back, and I want you in this position. And sometimes for certain reasons, everybody can't do that, but typically I'll lay the folks back. And certainly if somebody was to pass out, you want them not to fall out of your chair, right? So I think that's a better position for them to be in anyway. This is interesting. After that needle is coming out, no matter what, I learned to praise the patient. So they might have done awful in your experience, but they might have screamed or let out a yelp. But if you say, you did a great job, they'll say, I did. And the ones that really don't will really say, I did. And you say, yeah, you really did a great job. But what that does for them is it frames the whole experience for them. So in a couple weeks later, if they have to come back for maybe a second plantar fascia injection, in their mind, you told them that they did a good job, and now that's how they perceive it, right? So instead of being your no-call, no-show because they got too anxious to get in the car and come see you, maybe they're going to come and you can follow through with their treatment. Praise them no matter what. There's no reason, I'd say never to leave this stuff sitting out on the table for 10 minutes before you enter the room. This is something to discuss with your medical assistants, but there's no advantage of just leaving things sitting out, right? Keep it in your pocket, have it in a Mayo stand outside the room, or cover it up. In the patients that truly have a phobia, I would consider pre-medication with Valium. It's not often, but sometimes I will prescribe Valium 5 milligrams number 1, take 30 minutes before office procedure. And this is a benzodiazepam that will cause some muscle relaxation and sedation. And I think that can go a long way for these folks. They'll take it 30 minutes before, and when I see them the first visit, we'll actually do their consent form for their office procedure then if it's required, and they know that they're not going to drive home. Somebody has to come with them. And I think there's real utility in this when you're running late in your clinic and you have one of these folks that's going to take some extra time. Instead of trying to rush through it, when they tell you about their problem, and the first thing you say is, "It's okay, calm down. We are not going to do this today," then they kind of start to listen to you, and they open their ears, and you can talk them through the process, what it's going to entail. And then when they are going to come back, you can schedule them to have some extra time so you can do what you need to, and this will be a better experience for them and better for you as well. Technically, the anesthetic should be warmer than that of the body. Thinking about the pH, Marcaine has a more acidic pH of 4.2 compared to lidocaine at 7.4, but the pH of what you're injecting can cause pain and stinging sensation. So you can alter that with sodium bicarb as a buffer. But again, it's not typically something that we do because that takes time, and we're trying to see many patients in our busy practice, right? From an injection technique standpoint, you can minimize their pain using a smaller gauge needle. You can deliver it slowly. You can pulse it. It's been recommended to start the needle deeper and inject as you withdraw that needle, coming more superficially. Again, you don't need to use more volume than you need. Use what you need, and if you know your spatial anatomy and you palpate and feel pulses and such, you can put this where it's needed, not just everywhere. I know you probably heard this too. Suddenly, right before the injection, the patient will say, "Wait a minute, aren't you going to numb this first?" And you're thinking, well, this is the numbing shot, right? But in real life, if they're getting these tattoos, piercings, waxings, laser hair removal, microablation, other places they might have experienced some of these lidocaine topical agents. These are EMLA and LMX4, which are applied topically. Tegaderm is then used to keep that in place, and then you wait 30 to 60 minutes. That stays on there, has its effect, but there's not been great reports on effectiveness. So this is not cheap. It takes a long time for variable rates of effectiveness. So again, in your busy practice, you might need to let them know, all right, this is going to hurt just for a second, but keep calm and we'll get you through this. We may be more familiar with these agents in our offices, ethyl chloride spray, and then we have aerosol vapocoolants. And these are very cold to cause evaporation and change the skin temperature. They're sprayed from 3 to 9 inches away for a couple seconds and really should be stopped before the skin turns white. The ethyl chloride here runs about $50, whereas these cans are more like $5, excuse me. And then there's some other agents like a plastic container of water that turns into ice that could be reusable for about $15. You have to be careful not to leave this on there too long because it can certainly cause chemical burns and alter skin pigmentation. There's been questions as to, is this sterile when we're giving an injection right at that same spot? And there was a nice article in JFAS a few years ago basically saying that there have not been any reports in the literature of it being a breach of sterility. Now, if you use these products, I'm sure you've heard both of these. Some patients will say, please freeze it the entire time. They'd rather have the frostbite. They want it frozen the entire time. And other folks will say, the cold hurt worse than the actual injection. So I try on injection number 2 just to ask them, how'd you tolerate that last time? Certainly if they didn't like the ethyl chloride, I'm not going to waste it on them again. So it's something to gauge on injection number 2 for sure. Again, looking at some of these products, and this is our vendor magazine, but you can see these aren't too much. There's more expensive options if that's what you want. And then the ethyl chloride products are a bit more expensive. This box of 12 runs at a rate of about $43 each. I thought this was interesting. The ethyl chloride spray over here, each individually they sell it for $139. You don't get the discount until you buy, a bigger case. So it might even be worth considering, don't buy one of these things. You're gonna pay a couple times the amount for it. Buy it in bulk. Okay. How else can we distract the brain when somebody's getting an injection? Noise is a big one. In these gentlemen's sports of golf and tennis, you see these signs, they hold up, quiet please, and at Wimbledon they post signs, quiet during play. But we're in your home, and it's our home court advantage, so we're going to distract the patient as best as we can to mold their experience, right? So at basketball games, they hold up these heads and signs, and they wave these streamers as somebody's focusing on shooting a foul shot. And it's very difficult to focus on anything when you see some of this happening. Watch this guy on the left. Imagine seeing that right when you go to shoot a foul shot. This one on the right is my favorite. He goes to kick a field goal, and there's 20 other field goals behind it on the Jumbotron. Try focusing on that, right? So in your office, you got home field advantage. You can use these things the way you need to. And nowadays, most of our patients have cell phones, and we're familiar with how dangerous cell phones are with driving because they're major distractions. It's a manual distraction. They have something in their hand, they're touching, they're swiping. It's a visual distraction. Their eyes are off the road. They're not focused on something ahead of them. And then it's a cognitive distraction because now they're thinking about something else, and suddenly they arrive at their destination and maybe don't even remember getting there. So it's very unsafe, but something that we can use in our office. So I think of it like this. When the needle entry is going to occur, I have them taking deep audible breaths in and out, and I want them at maximal exhalation. And I think that does help with how they perceive the injection. And if nothing else, they can't scream because they just got rid of all the air in the lungs. Okay, you can let them play some music, let them be distracted by their cell phone. Ask them a question, get them thinking. If it's the talkative type of patient, ask them an open-ended question and let them do the talking. You might even tell them a joke to get their mind off of it. The sleight of hand to not show them the needle is something I'll touch on. And then there's some cold and vibration units on the market that we'll look at as well. This product is out of Australia. I was not able to get a cost on what this runs. This is called Smiley Scope, and there was a study discussing a 60% reduction in pain for children receiving allergy injections. I think nowadays, again, most people have a cell phone with them. The parents could give them a cell phone, hold it up. It does not have the blinders on the side like this thing does, but might be able to achieve something cheaper and about the same effectiveness. For this example, this is what they would see. This penguin talking to them and, just getting their mind off of an office procedure as it happens to them. This is not uncommon. Whether it's the patient or somebody else in the room, they might completely cover up their eyes with something that restricts their breathing, which might not be good, right? Or just turn the other direction. I like this one. This is called Bionics. This is a 2-point discrimination product. It's called a shot blocker. And the concept here is if you apply this near the injection site and already provide a stimulus in the receptive field, another stimulus is not going to trigger the same sensory input of pain. So this is kind of prickly. It does not hurt, but there could be questions of sterility since it has to be so close to the injection site. If you can see me, it looks like this. It's pretty small. I thought Dikembe Mutombo was the largest shot blocker that I ever met. I wasn't sure how effective this would be, and I have started to use this on some patients, and I think it does help some people, but it's not dramatic in my experience. A bolo punch, this is a martial arts technique. No, we're not punching the patient, right? But the concept here is the fighter on the left, his leading arm is going to do a jab to the fighter he's combating. And it's a slow jab that you kind of leave out there to get in the way of his vision so that you can follow up with a second punch. And that's kind of my analogy for what I also like to do as far as setting them up for attack. So right before the injection of their plantar fascia, their heel, I will have my hand on their hallux, and I'll squeeze their hallux about a second or two before the strike to the heel. And again, that's just throwing the mind off and tricking them. And sometimes they don't even perceive that you've done that, but that can help dampen the input going to their brain. Okay, getting toward the end here. Buzzy is a nice device that I've been using for probably the last 10 years. It looks like this. It's about the size of an old school beeper and vibrates just like an old school beeper would, but it's got a slot on the back where you put a little flat pack of gel that hardens up and turns into ice. And this provides vibration and cold just proximal to the injection site. And again, impacts their perception of pain by stimulating them in other ways. These run about $45. You can leave it on there for just 15 seconds before the injection, or sometimes I'll leave it on for a few minutes before the injection. You're familiar with whacking your finger or hitting your finger, and what's the first thing you do? You probably squeeze it, right? What you're doing there is you're sending pressure input to your brain to overpower the input coming from the pain receptors. And this device has the same concept, using cold input and vibration input to overpower the pain input. And this philosophy is called gate control. If you watch this little video here, the pain sensors and pathway is thinner and not insulated as well as the motion and cold sensors. And this all gets integrated in what's called gate control in the spinal cord. And as Buzzy's put in between the pain and the brain, the motion and the cold effects get taken up to the brain and processed by the thalamus, and the pain kind of gets blocked in a sense. And looking at this, there wasn't literature specifically for foot and ankle, and Dr. Vlahovic and I and some students, we did a little clinical study. We looked at 108 patients in total, pediatrics, and 40% were a control group, and they just got ethyl chloride, the spray. And then the 68 treatment group, they also had the ethyl chloride, but also the effects of Buzzy, and they reported a reduction using Buzzy from 5.4 to 3.4. So it reduced the perceived pain by a magnitude of 2 out of 10 on their pain scale. There's been other literature in other areas to validate it too. In conclusion, I will use the Buzzy device, not on everybody, but especially those that are more anxious about their injection. Before the procedure, I'll set the mood by talking to them, maybe affecting the lights, allowing for music. I'll instruct them to take deep audible breaths in and out, and I'll inject them during exhalation. And an assistant will do the aerosol or the ethyl chloride spray. And you'll see it as I squeeze the hallux and go to insert the injection here. So I'm stabilizing the hallux in case they kick or anything as well, but I'll squeeze that right as the needle goes in. Talk them through it. They're not seeing what's going on, they're leaned back. Even before the needle comes out, just a second before, I tell them the needle's already out, and I let them know they did a great job. And immediately we're going to apply firm pressure with a gauze to stop any bleeding, and again have that effect to overpower with pressure the painful stimulus going up to the brain. And this is just an example of a case. A kid came in with a splinter, deathly afraid of getting this needle injection. By using Buzzy over his posterior tibial nerve and deep perineal nerve more proximally, I think this helped him. I was able to get him numbed up and perform a little incision drainage and take out that splinter. So you too can be as cool as ice. And just with injections, I tell patients it's worth a shot. If you think that's worth a shot, maybe there's some potential options for you. Thank you very much.